Okay, everyone. So today I will be presenting Safety First, Practical Approaches to Preventing Medication Errors in the Hospital Setting. So before we begin, I just want to mention that I have nothing to disclose. Some pharmacist and technician objectives, I'll just kind of summarize them because they are very similar. So today we'll be differentiating between medication errors and adverse drug reactions, discussing medications or practices likely to increase the incidence of medication errors, to describe practices pharmacists and technicians can take to mitigate and prevent medication errors, to outline the Institute for Safe Medication Practices, the Joint Commission, and National Patient Safety Goals on patient safety guidelines for error and prevention, to identify which organizations and programs to report medication errors or incidents to on both the institutional and national scale, to discuss the evaluation of medication errors and measures taken to improve and prevent them from occurring again. So a study from the Institute of Medicine, To Err is Human, which was published in 1999, increased awareness of the prevalence of medical errors. And the study found that up to 98,000 Americans die each year in US hospitals due to preventable medical errors, with 7,000 of these deaths being from medication errors alone. And these numbers actually understated the problem because they did not include preventable deaths due to medical treatments outside of hospitals. And a recent meta-analysis of studies spanning from 2000 to 2019 suggests that 1 in 20 patients are exposed to preventable harm in medical care, with 25% of incidents being medication related. Medication errors impact an estimated 1.5 million people every year. So it is really important to note the prevalence of these errors. And today we'll be focusing on guidelines from the Joint Commission and the Institute for Safe Medication Practices, which are two organizations actively involved in improving medication safety. So what are medication errors? The National Coordinating Council for Medication Error and Prevention, or the NCC-MERP, defines a medication error as any preventable event that may cause or lead to an inappropriate medication use or patient harm while the medication is in the control of the healthcare professional, patient, or consumer. And this can include errors in prescribing, order communication, product labeling, packaging, dispensing. So it's important to keep in mind that not all medication errors can cause harm, but when they do, they may be called adverse drug events, which are a subset of medication errors and are defined as an injury resulting from medical intervention related to a drug. Adverse drug events are not usually avoidable, whereas medication errors are, and I included this figure to help describe the relationship between the two. So I included this scenario to help differentiate between medication errors and adverse drug events. A 55-year-old female has a history of herpes zoster. She reports considerable shingles pain and received a prescription for pregabalin. She returned to the clinic with complaints of ankle swelling, which required drug discontinuation. So is this considered a medication error or an adverse drug event? And I'll give everyone a minute to respond. Okay, so this is actually not a medication error made by the prescriber of pregabalin or by the pharmacist who dispensed it. Rather, this is a side effect that can occur with the use of this drug. So this would be considered an adverse drug event. So errors may fall into several categories, including errors of omission, commission, and system errors. Errors of omission are generally when something has been left out. Errors of omission include problems such as failure to include all prescriber instructions, subtherapeutic doses of medications, failure to check patient allergies, or to counsel on medication. Errors of commission are when something has been done incorrectly. So for example, dispensing the incorrect medication, providing the wrong dose or instructions, or incorrectly transcribing during medication reconciliation. System errors are those not exclusively because of an individual's action, but rather errors that result from actions or factors that are part of a process. So for example, environmental factors that distract the pharmacy team members during the medication use process, such as inadequate lighting, lack of double checks, and no policies on double checking patient names or birthdays that result in errors. So I included this illustration of the Swiss cheese model, which some of you may be familiar with. So to explain the complex and layered healthcare system and how each healthcare worker could potentially prevent and cause medication errors, James Reason proposed the Swiss cheese model. And according to this model, a series of barriers are in place to prevent hazards from causing harm to humans. However, each barrier, such as system alarms, administrative controls, surgeons, nurses, etc., has its unintended and random weaknesses or holes, just like Swiss cheese. And the presence of holes in one of the slices does not normally lead to a bad outcome, but when by chance all holes are aligned, the hazard can then reach the patient and cause patient harm. So this model illustrates how analyses of major accidents and catastrophic system failures tend to reveal multiple smaller failures leading up to an actual hazard. And just to piggyback off of the last slide, in correlation to the Swiss cheese model, experts in med safety agree that the most common cause of medication errors is a problem with the design of the medical system itself, not usually an individual making an error. And healthcare professionals should find ways to improve the system rather than focusing on the individual making the error. So errors will always occur, but the goal is to design systems to prevent medication errors from reaching the patient. And some at-risk behaviors that can compromise patient safety are included here for your perusal. So I included this example to help really conceptualize the Swiss cheese model and system-based causes to help drive it home. So in 1995, a 39-year-old medical journalist received a 4-fold overdose of a chemotherapy agent for 4 consecutive days at the Dana-Farber Cancer Center. The physician wrote the order incorrectly, the pharmacist did not catch it, and the nurses that were specifically trained in the administration of chemotherapy also missed the overdosage. And as a result, this patient died. So this is a clear depiction of how the Swiss cheese model can really come into play. The end result here was a culmination of errors made from multiple people that slipped through every barrier. Next, I want to discuss results of a pharmacist liability report, which involves a thorough analysis of pharmacist liability claims to provide insight on medication error types and causes. And the goal of this report is to help pharmacists enhance patient safety and minimize liability exposure by providing up-to-date information on professional liability claims and patterns and trends, as well as related risk management information and guidance. So just to give a little bit of background, if you look at the chart on the left-hand side, this displays the percentage of error claims made by pharmacy type. The pharmacy types with the highest distribution of closed claims are independent or individually owned, compounding, specialty, and national regional chain pharmacies. Hospital pharmacy, as outlined here, represents 8.2% of pay liability claims. And if we move on to the right-hand side, it shows the cost effect that is a direct result of medication errors. And the 2 types of pharmacy locations with the highest average total incurred include hospital and compounding specialty pharmacies, which is interesting considering how hospital pharmacy only accounted for 8.2% of paid claims. So hospital pharmacies, as shown, has an average total incurred of almost $300,000, which is more than 2 times the average total incurred of about $120,000. And the main driver behind the higher average is due to significant injuries to already acutely ill patients. So that was something to note as well. And moving forward, the chart on the left here displays the 7 allegation categories that resulted in an average total incurred that was higher than the overall average total incurred of about $120,000. And the allegations that were associated with the highest paid claims were failure to identify overdosing, compounding, calculation, and or preparation errors, and libel or slander. So claims that were associated with falsified statements were actually associated with a significant amount of money. Now to get into the distribution of error claims, wrong drug and wrong dose continue to be the most common allegations at a combined 52.1% of all closed claims, and this represents a decline from a combined 75.3% in the 2013 report. So this is likely due to adoption of barcoding measures and electronic prescribing. And the most common factor associated with dispensing the wrong drug and wrong dose was failure to separate look-alike, sound-alike drugs, failure to question unusual orders, and failure to monitor and clarify anticoagulant therapy. So this is something to keep in mind, especially within this setting, as these errors are still very likely to occur in our daily practice. And consequences of these errors is significant and shown in this chart here. And the consequences that I really want to emphasize are patient death, permanent patient harm, and temporary patient harm requiring intervention or prolonged hospitalization. So if you look at these percentages of occurrence, which is 11.3, 17.4, and 41.3% respectively, you can see a pretty significant outcome associated with these errors. And also from a monetary standpoint, I want to point out how much money was spent as a result of the consequences of these errors. And the takeaway from this slide and this analysis altogether is that we must be more aware and try to limit medication errors, not only for patient safety, but for cost savings as well. Next, I want to discuss the regulatory bodies that help ensure patient safety, which I'm sure a lot of you are already familiar with. So the Joint Commission is an independent, not-for-profit organization that accredits and certifies more than 17,000 healthcare organizations and programs in the US. And every accredited organization must undergo an on-site survey at least every 3 years, and surveys can be unannounced. And the Joint Commission puts together national patient safety goals, which are set annually for different types of healthcare settings. And that includes ambulatory care settings, hospital settings, and behavioral health clinics. And those are just some examples. And each goal includes defined measures under elements of performance that must be met. And these will usually be embedded within the institution's protocol. And I included some important examples of national patient safety goals for pharmacists and technicians here, as described here on the slide. So the first one is the use of at least 2 patient identifiers when providing care, treatment, and services. And appropriate patient identifiers include name, medical record number, and date of birth. And the second one that I want to highlight is reducing the likelihood of patient harm associated with use of anticoagulant therapy. So using approved dosing protocols and programmable pumps for heparin, and providing education for patients. Protocols should include starting dose strategies, alternate dosing strategies to address drug-drug interactions, and requirements for a baseline INR. So for example, every time we verify warfarin, we enter the INR within PharmNet. So that's an example of how we incorporate that into our practice here. And the third national patient safety goal that I want to highlight is maintaining and communicating accurate medication information. And this includes medication reconciliation, providing written information to the patient, and conducting discharge counseling. And it's very important to maintain communication, whether that be verbally or in written form. Next, I want to discuss the Institute for Safe Medication Practices, or the ISMP. So the Institute, or the ISMP, is a nonprofit organization that's devoted entirely to preventing medication errors. And they provide best practice guidelines and recommendations to hospitals based on error reports received via their reporting system known as the ISMP MERP, which we will discuss in further detail later on. And in the past 25 years, ISMP has provided tools and resources for healthcare professionals to help prevent errors and has defined key elements of the medication use system. And ISMP notes that medication use is a complex process that comprises the sub-processes of medication prescribing, order processing, dispensing, administration, and effects monitoring. So if you look at the ISMP's key elements here, and these are just some that were listed, you can see how many errors can occur during drug labeling, packaging, standardization, and distribution, and how poor staff education can also increase the risk of error potential as well. But these, again, are just some examples that I've included. So now we'll be moving on to errors associated with the medication use process. So both ISMP and the American Society of Health System Pharmacists, or ASHP, agree that addressing medication errors requires an understanding of how and why they occur during the medication use process. And helpful guidance documents that we discussed previously have been developed by both ASHP and the ISMP that incorporate the Joint Commission's medication management system. And I combine both of ASHP's and ISMP's elements of error potential in the different aspects of the medication use process as pictured here on the slide. So errors can occur in various steps of the process, but our focus today will shift towards selection or procurement, patient admission, preparation, dispensing, and patient discharge. Both ASHP and ISMP's frameworks provide a useful construct to think about where medication errors can occur and ways to minimize risk within each area. So now we'll be shifting our focus on risk reduction measures. So selection and procurement of medications involves appropriately selecting which medications will be stocked in the institution and then safely and effectively obtaining the medications from manufacturers and wholesalers. So best practices for decreasing the risk of errors during selection and procurement can generally be divided into 5 categories as listed here in blue. And the first category is formulary management, which allows providers to prescribe safe, cost-effective medications and to become familiar with formulary medication dosing, preparation or dispensing, and administration. And this formulary assessment is typically done through monthly P&T meetings, similar to our process here. And the second category includes limiting and standardizing the number of medication concentrations available to avoid errors in calculations, reducing waste, and efficiently managing inventory, and to help promote the use of premix solutions. So the third category is safety alert monitoring, which involves having designated team members from the pharmacy assigned to actively monitor medication safety alerts via the organization's error reporting program. The fourth category is ensuring safe procurement practices, which involves having the pharmacy department responsible for all procurement within the organization, including how to handle patients' home medications and samples. So for example, like our policy here, all patients' own meds must be brought down to the pharmacy for verification prior to use to ensure safety. And the fifth category is a subset of safe procurement and includes effective management of drug shortages, including communication to the providers to help figure out alternatives and also to maximize efficiency. So for example, we have had a shortage of IV hydralazine, but effective management includes recommending alternatives such as IV enalaprolat, for example. So moving on to patient admission and discharge. So there are several best practices that can help prevent med errors during these steps, including medication reconciliation. So medication reconciliation, or MedRec, involves comparing a patient's medication orders to all the medications that the patient has been taking at home. And this is done to avoid medication errors such as omissions, duplications, dosing errors, or drug interactions. And it should be completed at every transitions of care in which new medications are ordered or existing orders are rewritten. And transitions of care includes change in setting, service, practitioner, or level of care. So common examples are hospital admission, transfer into or out of the ICU, and at hospital discharge. And pharmacists and technicians should be involved in the medication reconciliation process before discharge. And upon discharge, patients and their caregivers should be counseled about their medication, which also provides an important double check in the medication use process and provides the patient with the needed information to use the medication correctly. And this helps limit discrepancies in patients' medication lists to make sure that we're optimizing their therapeutic regimens and minimizing mistakes. Medication errors post-discharge are a cause of avoidable hospital readmissions and are the most common cause of post-discharge adverse events. So by rectifying patients' med list prior to admission, using the stepwise approach highlighted here in yellow, it will help prevent avoidable errors post-discharge. So this was an unblinded, cluster randomized, controlled investigation of medication management plans for patients discharged after an inpatient stay in a general medical unit. So the aim of the study was to evaluate whether pharmacists completing the medication management plan in the medical discharge summary reduce the rate of medication errors in these summaries. And patients randomized to the intervention arm received medication management plans completed by a pharmacist, which was the intervention, and those in the control arm received standard medical discharge summaries, which was the control. And the primary outcome variable was a discharge summary, including a medication error identified by an independent assessor. So To get into the results, at least one medication error was identified in the summaries of 61.5% of patients in the control arm, compared with 15% of patients in the intervention arm. And the absolute risk reduction was 46.5%, with the confidence interval that showed statistical significance. The number needed to treat here to avoid one error was 2.2. And this means that 2.2 patients would need to be treated for a certain period of time in order for one patient to benefit. So the results of the study clearly depict the value of having pharmacists completed medication reconciliations on limiting error. So now we'll be moving on to transcribing and reviewing errors. So transcribing errors are defined as any deviation during the transfer of information from an order sheet to documentation forms or medication administration records. And transcribing involves orders that are manually transcribed into written records and those that are electronically transcribed into the electronic health record. And some of the contributing factors includes MedRec discrepancy, so making sure that we're really transcribing the patient's medication list appropriately and accurately, incomplete or illegible prescriber orders, incomplete nurse handwriting, and use of error-prone abbreviations are common causes of transcribing and reviewing errors. So we should always clarify any unclear orders and not process anything that is incomplete. And of course, always minimizing the use of those error-prone abbreviations. So I included some of the do not use abbreviations per the Joint Commission. And the one that I really want to highlight is the use of decimal point errors. And these are important because they can result in severely fatal dosing errors. A written dosage form can be easily misinterpreted if there is no zero before the decimal point. This could lead to the patient experiencing an adverse reaction or outcome. And a leading zero can prevent a decimal point from being missed. So we should always minimize the use of these abbreviations and always double check everything. So due to the adoption of CPOE, or computerized provider order entry, and electronic health records throughout the years, the risk of medication errors has decreased significantly by minimizing ambiguity resulting from handwritten orders and by implementation of clinical decision support tools or the pop-up alerts that we get to assist in verification. And to substantiate this benefit, I've included the results of a systematic review. So the authors conducted this review with this primary endpoint in mind, as listed on the slide. So they were trying to establish the percentage and absolute risk reduction in medication errors. And the study found that processing a prescription drug order through a CPOE system decreases the likelihood of error on that order by 48%. And I want to point out that this result is statistically significant as it does not cross 0 or 1. And given this effect size and the degree of CPOE adoption and use in hospitals, the authors estimated a 12.5% reduction in medication errors, or about 17 million medication errors averted in the US in 1 year. So the findings here suggest that CPOE can substantially reduce the frequency of medication errors in inpatient acute care settings. So while electronic prescribing has many benefits on limiting those transcription or reviewing errors, there are still different types of errors within this process that can still occur. And prescribers need to be familiar with the organization's medication ordering system, and orders should follow hospital policies. Orders should include patient identifiers, route and site of administration, dosage form, strength, quantity, frequency, and duration of treatment. And for IV medications, the concentration, the rate, and time of administration should be specified as well. So we should always be double checking every order for the following here, as these are areas where there could be potential errors. So now I want to discuss some best practices we as pharmacists can implement during order entry. It is important that we get the proper end user training. I know it's easy to click through learning modules. However, it truly is important to familiarize ourselves with the system that we use and stay up to date with changes to the system. Also, more often than not, the new medical residents are not as familiar with the ordering system and order medications incorrectly. We should always be willing to assist in the ordering of medications when we can to ensure medication safety. And with that being said, we should always encourage the use of our institutional power plans and protocols, as the standardization allows for not only medication safety, but ease of use as well. Examples of power plans that help standardize treatments are a heparin power plan or an insulin DKA power plan. When verifying orders, it is common for prescribers to prescribe medications that patients may have an allergy to. So for example, if there's a penicillin allergy listed, always assess the risk and determine if it is a true allergy. But if penicillin use is absolutely indicated, we can recommend desensitization protocols to limit the risk. Another common mishap is when providers change the dose of a medication and enter a new order for it. And they don't always take into account when the patient received the last dose of the previous order that day. So we should always thoroughly evaluate any of the medication alerts that pop up during order verification. I know it's easy to choose therapy part of MD regimen because, you know, the alerts may seem redundant, but it's really important to be mindful that these alerts are put in place for a reason and may catch something that you might have missed. An adoption of national e-prescribing standards, improved usability and end user training are really, recommended to address these issues. So now to move on to dispensing errors. So these are some examples of dispensing errors that can occur and have occurred during the dispensing process. The most common were dispensing the wrong medication, dispensing the wrong strength, and dispensing the wrong dosage form. And lack of auxiliary labels are also a common dispensing error that can occur throughout the process. And it is important that we use auxiliary labels to alert nurses of proper safe use precautions of the medications. Look-alike, sound-alike drugs are also a common cause of dispensing errors as well, which we will get into further. Another thing that's pertinent to point out that is more of an FYI because it more so pertains to nursing, but unsafe overrides have occurred in the automated dispensing cabinets. And an example of this is a nurse that gave vecuronium instead of Versed to a patient, which led to patient death. And this error was due to the ability to type in both brand and generic names when choosing a drug. So it is important to standardize our Pyxis machines and utilize only generic names of drugs, as this limits the potential for drug-drug mix-ups. So common types of human error involve confirmation bias, which is seeing or hearing what is familiar or what a person wants to see or hear rather than what is actually there. And some factors that contribute to this are similar packaging, difficult to read labeling, similar shape and size, or drugs that are a similar color as well. So when putting orders away, a lot of the ready-to-use packaging looks very similar. So it's really important to be organized during order time because you can only scan one out of however many boxes you're putting away for a drug into its bin into the VC. And another example of confirmation bias is what we think of when we think of Zosyn IV. When we see Zosyn IV, we think of the 4.5 gram bags with the red labeling with white lettering. So it's easy to overlook something pertinent on this when checking medications because we think we know exactly what we're looking for, but it might be different than what we imagine it to be. So there has actually been a Zosyn shortage leading us to having to add a vial of the bag. So it's important to be mindful of drug shortages and different manufacturers that may supply us due to these shortages because things will not always look the same. So look-alike, sound-alike medications are a common cause of errors, and it's usually because the similar product labeling aggravates this. So using tall man letters, which mix upper and lowercase letters, draws attention to the dissimilarities in the drug names. And the letters that are uppercase are the ones that are different between the two look-alike, sound-alike drugs. And I've included some of them here on the slide, amlodipine versus amiloride, buspirone versus bupropion. So, the key differences are the ones that are uppercase in the medication name. So I've also included a list of our institution's look-alike, sound-alike medications to help familiarize yourself and be more cognizant of the medications that we keep in-house that may look or sound like another medication. So moving on to dispensing best practices, double check should be built into the medication management and workflow processes. So for example, using barcodes to scan the drug label against the NDC ordered. And when possible, we should always use commercially available medications instead of compounding. Oral and parenteral medications should be dispensed in the most ready to administer form. And auxiliary labels should be used along with ensuring label readability to minimize issues after dispensing. Auxiliary labels help alert nurses and providers about pertinent information during the administration process. So for example, if 2 tablets are needed to provide 1 dose, you can use the orange note dosage sticker. So we should always adhere to USP processes such as 797 and 800 to ensure sterility when compounding IV preparations. Also, I know John Bruno sends emails about ISMP alerts. It is important to read over these med safety alerts to familiarize yourself with the errors that have occurred to prevent them from happening within your practice. And finally, it's important to address environmental factors that may contribute to dispensing errors, including ensuring adequate staffing levels and breaks, eliminating distractions in the dispensing process, so the use of phones, radios, and really just trying to reduce the clutter and ensuring adequate space and proper storage of drugs. All of these environmental factors, have been associated with medication errors. So it's important to keep the workplace organized and well-equipped to minimize error potential. I included a picture of some of our pertinent auxiliary labels that we use here in the main pharmacy for our IV and high-risk medications. In addition to sound-alike or look-alike drugs, high-risk medication should be flagged with additional care taken to ensure the correct medication has been selected with the correct dose. High alert medications are drugs that bear a heightened risk of causing significant patient harm when they're used in error. And ISMP maintains lists of high alert medications for both the acute care and community and ambulatory pharmacy settings as well. And an example of these medication classes in the institutional environment are listed here in the slide for your perusal. So insulin, anticoagulants, and paralytics are common ones. ISMP suggests using auxiliary labels, shelf labels, automated alerts, and standardizing the storage, dispensing, and administration of these products to really help minimize the risk potential. So this is a list of Stony Brook's high-risk intravenous medications. This is a great mnemonic to remember called ACLIPS, which stands for anticoagulants, calcium, Lanoxin, insulin, potassium, and sodium chloride at any concentration higher than 0.9%. IV anticoagulants have a high risk of bleeding, so it's important to assess both the bleeding and the thrombotic risk to assess for efficacy and safety via APTT monitoring, hemoglobin, or hematocrit monitoring. And we have power plans here to assist with titration parameters to help with standardization. Calcium chloride or gluconate is high risk when given IV push or given via rapid replacement due to the risk of extravasation, arrhythmias, or kidney failure. And calcium chloride really bears more of a risk because of the higher content of calcium. Next, digoxin is a high alert medication due to its narrow therapeutic index, and it's usually considered toxic at serum levels greater than 2 nanogram per ml. And toxicity may also increase with hypokalemia, hypomagnesemia, and hypercalcemia. So it's important to be mindful of those lab values as well. Insulin has a high risk of hypoglycemia, which is life-threatening and why it is on this list. Potassium has a high risk of extravasation and arrhythmia such as bradycardia or ventricular fibrillation, which could lead to death. And parenteral potassium replacement is never administered via IV push. Hypertonic saline has a high risk of extravasation, osmotic demyelination syndrome, which can lead to coma or death, and it is primarily administered via a central line. And as per our hospital policy, we require a second nurse check and signature in the computer for the administration of our high-risk medications. So just to go into more detail on some examples of safe use precautions we have here, I've included our policies and standard procedures for insulin. So ISMP recommends to standardize all insulin infusions to 1 concentration, which we do have here at a concentration of 1 unit per ml. All insulin infusions are to be dispensed from pharmacy, and this is different from the sub-Q dosage forms such as Lantus or Lispro, which can be dispensed from the automated dispensing cabinets. ISMP also recommends to develop protocols for insulin infusions and to transition from infusion to sub-Q and sliding scale orders, and to use standard order sets for management of hyperglycemia or hypoglycemia. And all of this is generally available through our institutional power plans. And again, I always want to place an emphasis on the use of our auxiliary labeling to help alert nurses about the high risk associated with these medications. Next, I want to go over some pertinent safe use precautions for potassium. ISMP states that we should use protocols for potassium chloride delivery which include indications for IV administration, maximum rate of infusion, maximum allowable concentration, and guidelines for when cardiac monitoring is required. And first and foremost, potassium should never, ever be administered IV push. There was a case recently released by ISMP of a pharmacist in the ICU recommending potassium to be given IV push, which resulted in patient death. So I do want to make that clear. Some examples of our potassium policies in reference to this are as follows. So the max concentration for maintenance replacement in adults without cardiac monitoring is 60 milliequivalents per liter at a rate not to exceed 10 milliequivalents per hour. And in reference to rapid replacement, acute care units can contain intravenous solutions with the max concentration of 10 milliequivalents in 100 ml given over 1 hour. And no more than 40 milliequivalents are given before monitoring of a potassium level is obtained. And in the ICU, the max concentration that can be given is 20 MEQs per 100 ml over 1 hour, and also requires central venous access. And no more than 60 milliequivalents can be given IV before a serum level is obtained. And in the cardiothoracic ICU, 30 milliequivalents per 100 ml given over 1 hour must be given centrally, and this dose may be repeated if the potassium is still less than 3.6. So now to get into evaluation of errors and error reporting. So evaluating medication use systems and processes is a critical ongoing effort that should be undertaken by hospital organizations. And these analyses focus on why an error occurred by collecting data about that error, identifying the root cause, and creating recommendations to prevent an error from reoccurring, and then implementing those recommendations. So evaluation and quality improvement can be performed prospectively, retrospectively, or continuously. And the FMEA, or the failure mode and effects analysis, is used to analyze the design of the system in order to evaluate the potential for failures and to determine what potential effects could occur when the medication delivery system changes, or if a potentially dangerous new drug will be added to the formulary. A root cause analysis is a retrospective investigation of an event that has already occurred. And this includes reviewing the sequence of events that led to the error. And the information obtained in the analysis is used to design changes that will hopefully prevent future errors. So CQI is the goal of most healthcare settings. It's what we all strive to achieve. And continuous quality improvement programs improve efficiency, quality, and patient satisfaction, while also reducing the costs. And all in all, these methods are used to obtain quality control and better our system. So medication errors, preventable adverse drug reactions, hazardous conditions, and close calls or near misses should be reported. Medication errors are reported so that changes can be made in the future. And without reporting, these events may go unrecognized and will likely happen again because others will not learn from the incident. Many medication reporting systems within hospitals are electronic. So here at Stony Brook, we utilize SB Safe. So to access this, you can go to the intranet, go to quick links on the right-hand side, and find SB Safe as shown here in the slide. Once you click SB Safe, you can find up to 24 scenarios that you can file a report for. I've included some of them here for your reference. And once you click into the best fitting one, you will be able to file a complete report on what occurred, and the Medication Safety Committee will take this into consideration to prevent any error from occurring again. So in addition to internal medication error data and review, data is available from voluntary national error reporting programs. And these programs use the reports gathered to educate healthcare providers about error causes. So I'm sure you've heard me mention ISMP throughout this presentation. So I want to highlight exactly what it is. The ISMP MERP is a confidential voluntary practitioner-based medication error reporting program, and it provides expert analysis of the system causes of medication errors and provides recommendations for prevention. Medication errors and close calls can be reported on the ISMP website. as well. Another outlet for error reporting is the FDA's MedWatch program, which includes both voluntary and mandatory error reporting. From a healthcare professional or consumer standpoint, reporting is voluntary, but again, always recommended. Pharmaceutical companies and manufacturers, on the other hand, are mandated to report any errors or defects to help initiate recalls or market withdrawals as needed. So the reason it is so important to report errors, especially from an internal institutional standpoint, is because we can acknowledge how and why the error occurred and actively find ways to prevent them from occurring again. Additionally, from an external reporting standpoint, post-marketing data provides valuable information that can result in labeling changes, warnings, recalls, or drug withdrawals. And error reporting can help prevent patient harm and maximize quality control on a much larger scale. Lastly, I want to point out that reporting is never meant to be punitive, as I know this may be a cause of hesitancy. The purpose of these reporting outlets are to implement change and never to blame the individual themselves, but rather the system as a whole. So you can be the change by making an active effort to report these errors so the system can find ways to improve. And that is all for today. Thank you all for coming. If you have any questions, please feel free to ask and I will be happy to answer them. And if you can, please drop your name in the chat box if you have not done so already, just so I can keep track of attendance and send you my post-assessment questions via email. Okay, thank you all for coming.